Dear Chairman, thank you for the invitation to present at the EBC 2001 meeting. The title of my presentation is Side Branch Strut Opening May be Better Approach During One Stent Strategy. Purposes of side branch opening are following. However, the COVID-3 study did not show clinical benefit of side branch treatment. The latest consensus document introduced the fenestrated restenosis at CX ostium 3 years after crossover stenting. In this patient, everolimus eluting stent was implanted crossing over CX without dilatation of the CX ostium. She suffered from acute heart failure 5 years later. At that time, CX was totally occluded. When intervention was performed to the gelled CX, balloons were ruptured, so we performed rotablator followed by dilatation with scoring balloon and DCB. 1 year later, ostial restenosis was found again. We performed T-stent. But next year, CX was occluded. Then he underwent bypass surgery. When we declined to open the side branch during initial procedure, we occasionally need complicated and difficult procedures later. The serial OCT observation of the gelled side branch without opening revealed that side branch ostium area decreased according to the gelling complexity. Small compartments divided by struts were filled with tissue attachment. However, kissing balloon may have potential problems. Meta-analysis showed KBI decreased risk of side branch restenosis, while an increased risk of main vessel restenosis. POT can induce a constant increase in cell size area of side branch ostium. In the e-Ultimaster bifurcation subgroup analysis, POT reduced consistently clinical events compared to no POT, while final kissing balloon did not show significant reduction of the events. Either use of POT or KBT reduced the clinical event. POT plus KBT showed the best clinical outcome, while the simple keep it open strategy showed the worst clinical outcome. This analysis suggests that POT should be done regardless side branch treatment. Improvement of kissing balloon technique has been reported. The short overlapping KBT has been introduced. The RAIN study showed the reduction of the TLR in the short overlapping KBT group. When side branch is open, the distal recrossing is recommended. In the optimal trial, however, the frequency of the distal recrossing identified by the first 3D OFDI was 55%. This suggests that 40% of side branch dilatation may not be performed optimally. Handled achievement of the distal rewiring under online 3D OFDI guidance reduced acute ether at bifurcation segment compared to the angiographic guidance. Our registry shows that frequency of angiographic side branch restenosis in the optimal side branch dilatation, which achieved both distal rewiring and no-stent link at carina, tend to be smaller than that in the other condition. If strut configuration is unfavorable for side branch dilatation, POT alone may be better choice than side branch opening without optimal condition. Decision making according to the 3D OCT findings may improve clinical outcome. After study period of COVID-3, new insights from imaging study and technical improvement of side branch treatment were introduced. The new techniques may improve clinical outcome. I'd like to summarize my presentation. I believe that side branch strut opening during single stent strategy should be performed because we may encounter the gelled side branch stenosis sometimes at very remote phase after single crossover stenting without side branch opening. Gelling struts with severe neo-intimal proliferation at side branch ostium could make it difficult to perform PCI. Contemporary best practice for side branch strut opening could improve clinical outcome. Thank you very much for your kind attention.